Hey, it's Dr. Muldoon. I just want to review a few post-op instructions to make sure that you are as prepared as possible for the post-op period. So first, if we're doing a laparoscopy, that means you're going to have laparoscopic incisions. Those incisions are usually by your hip bones and one at your belly button, sometimes one on either side. Those incisions at first will be itchy, and sometimes for some individuals they can get a little bit red. I just want you to keep in mind that itchiness and redness can be normal. It's different in every person. We find a lot of patients will reach out to us and let us know that they think they're infected, and certainly if you're concerned about that, feel free to reach out to us. But keep in mind that sometimes that itchiness can just be from skin healing. Just like when you skin a knee, a lot of times when you skin a knee, you'll notice that there's kind of a little bit of redness, yellow discharge, some of that granulation tissue. You can also sometimes notice that at your incisions, even at the belly button or on those side incisions. I always tell patients if all three incisions are misbehaving and if they're all three kind of red and itchy, the likelihood that they're all three infected is pretty darn low. The more common thing is that you might be having an allergic reaction to the glue or sometimes to the abdominal prep. So if you think that's going on, obviously let us know, we can walk you through it. But most of the time, we're gonna encourage you to take some Benadryl or use some Benadryl cream that's over the counter. And sometimes if someone's having a real rash, we can consider doing a hydrocortisone ointment or hydrocortisone cream from over the counter, or even a steroid taper orally. So keep in mind that not everything that is a little bit red is an infection. Sometimes they can just be normal healing, and sometimes it can be a little bit of an allergic reaction. Additionally, after surgery, I always tell patients, the second you wake up from surgery, you're likely constipated. The pain medication constipates you, and so keep that in mind as you're using the pain medication, but medicate yourself appropriately if you're having pain. Now, because you know that you're going to be constipated the second you wake up from surgery, I warn everybody that if you're not passing gas by the following afternoon, the day after surgery, then you should really consider doing something to help with that gas passage. So coffee, prune juice, stool softener, laxative, whatever you've got that you think might work, try to do something after surgery, especially that following day, to try to get things going. I'd rather have you have a little bit more diarrhea than feel really constipated and get a lot of abdominal pain from that. Keep in mind there's a fair amount of gas pain from surgery. We put gas inside your abdomen in order to be able to see, and a lot of times we push that gas out, but it can still cause pain, and the pain that it causes is a lot of shoulder and neck pain. So a lot of shoulder and neck pain, a little bit of referred pain just into that chest, into the shoulder and neck. So if you're noticing some of that afterwards, that's pretty common. I usually tell my patients that should improve with time. One thing that you can do to work on that is do some walking. Walking is important after surgery. You know, back in the day, we used to think that people should just lay in bed, and we've realized now actually that walking is the most important thing that you can do after surgery because it decreases your risk of getting blood clots in your legs that will move to your heart, brain, and lungs. So instead of getting those blood clots, we'd rather you get up. Now, I used to have patients who thought that meant getting up, you know, and walking a mile. No, it definitely does not. It means getting up and walking from, you know, where your bed is right now in pre-op to the door in pre-op. So just a couple of steps there and back really helps you to move your legs and to avoid getting blood clots in those legs that travel to the heart, brain, and lungs. In terms of postoperative pain control, everybody's different. So keep in mind that, you know, what I'm saying in this video might be a little different for you. But I always tell patients that the post-op period is where we learn the most about you and what you need for pain control. And every single patient is different. I will say I think everybody is fairly tough before they have surgery, and then not a single human, myself included, once they have surgery is quite so tough because surgery is painful. And so I always tell patients, I don't judge you on how much pain medication you need or how frequently, and there's no award for taking the least amount of pain medication. And so if you're having a lot of pain, we got to medicate that. Now, I usually send most patients home with ibuprofen, Tylenol, methocarbamol, which is a muscle relaxer, as well as oxycodone. So 4 different types of pain medication. And for some individuals, I'll even send them home with Zofran, which is also called ondansetron. That Zofran or ondansetron is an anti-nausea medication. And so if you're somebody who knows that you get nauseated by narcotics, then you'll want to pre-medicate the narcotic with the nausea medication, meaning that before you take the nausea medication, about 30 minutes before at least, that you take that nausea medication, pre-medicate it, kind of prime the line, so to speak, and then after that, you'll take the narcotic medication. Now, I usually tell patients, unless you have a reason why you can't take ibuprofen and Tylenol, I typically like for you to take the ibuprofen and Tylenol alternating the two for the first 3 to 5 days after surgery. Now, you don't have to wake up in the middle of the night to take it, but I would like for you to take it pretty regimented for the first 3 to 5 days. I always say that that helps with some of the inflammation of surgery as well as the pain of surgery. And so it's good for you to alternate the two and take them on a systematic basis after surgery. Typically, that's ibuprofen 800 milligrams every 8 hours and Tylenol 1 gram every 8 hours. So you're alternating Tylenol and ibuprofen every 4 hours because you're doing each one every 8. Now, if you're worried that you're going to forget all this, keep in mind that all of this is in your discharge instructions, but my job is to try to give you some of that insight right now, just so that you have a little taste for what you're expecting after surgery. Now, in addition to that, I write you the muscle relaxer. I always like to say that the muscle relaxer is a non-narcotic that gives you better pain control, but isn't quite so strong as a narcotic. And so I usually say if you're at a 4 to 6 out of 10, the muscle relaxer is a really good option, and you can add that into your ibuprofen and Tylenol regimen. And then in addition to that, I give you oxycodone. I typically start the dose at 1 tablet every 4 hours, but I warn people that every single patient is different. What does that mean? That means that for some people, 1 tablet every 4 hours is too much. They don't need it. For a lot of people, 1 tablet every 4 hours is the bare minimum. And for some people, 1 tablet every 4 hours really doesn't cut it at all. There are some people who do 2 tablets every 4 hours. And I've had patients who have had to do 1 tablet every 2 hours. So what does it depend on? Are you going to overdose if you take 2 tablets every 4 hours instead of 1 tablet every 4 hours? Well, the short answer is, like I said, we're trying to figure you out, and every single human's different in terms of pain control. And so some people need very little narcotic and some people need a lot. What I tell people is the oxycodone is not really something that you're overdosing on just by taking it at a higher frequency. The thing that we worry about is if you take too much too frequently, you're decreasing your respiratory drive, and you're gonna have trouble breathing, and we worry that you won't be able to breathe appropriately, right? So what I say to patients is if you're really zonked out, you're tired, you're sleeping, and you're not really in pain, you don't need to be taking a narcotic medication. We don't want to continue to give you more medication and quote unquote snow you. But if you're somebody who it's only been 3 hours, you're in quite a bit of pain, everything hurts, and you're not due for another narcotic for another hour, it really is okay to take that tablet of oxycodone a little bit earlier, given that you're at 8 out of 10 or 9 out of 10 pain a little bit earlier. You're not going to overdose like you would with ibuprofen and Tylenol, where you have to follow those parameters as to how frequently you take them, because those medications you can't take any more frequently than that. They can affect your liver and kidneys. Oxycodone doesn't really work like that. The way that it works is that it's a narcotic. It suppresses your respiratory drive. And so if you're taking too much, you're going to affect your ability to be able to take appropriate respiration. The other thing is I generally send you home with a medication that reverses the narcotic, and that's always just for safety. So if you're ever at a place where you need to take the medication, you feel like you have taken too much narcotic, you'll always have an option at home that you can self-administer for trying to reverse the narcotic. But it's exceptionally rare that anyone actually needs to use that. From the majority of individuals, when they get home, they start to understand their body a little bit better, and they realize, you know what, the ibuprofen and Tylenol and the muscle relaxer isn't enough. I need to take the narcotic, and perhaps I need to take it a little bit more frequently, nothing egregious, but a little bit more frequently than when I was initially taking it 1 every 4 hours. So if you're ever worried or you're not sure, feel free to reach out and we can talk about it. But truthfully, a lot of it is just getting to know you and getting to know what the right thing is for you. Now, the other pieces that I think are intangibles of surgery are, I tell a lot of patients the risks of surgery are bleeding, infection, injury to surrounding organs. For most patients, the plan is to do everything through small incisions, unless the plan otherwise was to do an open incision. But I always warn them there is always a chance of an open incision. Generally speaking, we try to send the majority of patients home the same day, assuming that they're safe. In large part, this is because we want you to get good sleep at home. As long as you have good support at home, we feel confident that you're able to get appropriate pain control, sleep, and avoidance of infection risk from the hospital setting. Now, if for whatever reason you're not doing well and we need to keep you overnight, we're more than happy to keep you overnight. And that just depends on how you're doing and what we're worried about that we want to watch. Now, after surgery, we do want you to start passing gas. Usually passing gas from down below should happen within the next 1 to 2 days. In terms of passing a bowel movement, that should happen within 2 to 3 days, sometimes a little bit longer if you're really quite constipated. And then I warn people after laparoscopic surgery, it's not uncommon that you're going to have some burning with urination. This is largely because we put a catheter inside the bladder, and so that can irritate the bladder quite a bit. We do get a lot of phone calls that are worried about urinary tract infections, and I warn patients that the majority of the time those aren't urinary tract infections, especially if that burning with urination is starting to get better after surgery. Now, if you're noticing that that burning is getting worse and worse and worse, let us know. We can definitely send in a urinalysis and take a look and see if a urine infection is actually brewing, but that's pretty darn rare. It's much more common that it's just the dysuria or painful urination from having that catheter in. Additionally, the first couple bowel movements after surgery can be tough, especially because you're constipated, and so having to strain doesn't feel great right after surgery. So I warn patients, those first couple bowel movements may be really uncomfortable, but after two, you really should start to notice an improvement in terms of how much discomfort there is. Now, additionally, if you're having any specimen like the uterus taken out, nothing in the vagina for 8 weeks, it's our biggest rule. I warn patients that the worst case scenario is that if something goes in the vagina or if someone has premature intercourse, that they could break open the vaginal cuff and cause bowels to come out of the vagina. And so really you want to try to avoid that as best as possible. Please, be respectful and don't use that vaginal area for at least 8 weeks if we're taking the uterus out. If we're not taking a uterus out and we're just doing a laparoscopy, I usually tell patients you'll probably wait 4 weeks before doing anything within the vagina. Now, additionally, I think in terms of just heavy lifting, anything over 10 to 15 pounds, we really don't want you to lift for 2 weeks at least. For some individuals, that's 4 weeks. Every single person is different, and it just depends on how your recovery is going. But I would definitely say no heavy lifting for 2 weeks. The biggest reason for that is because we don't want you to develop a hernia. And the hernia is where you develop a defect in the abdominal wall as a result of surgery, but also as a result of breaking the suture. So we really don't want that. We want you to really give your body a rest. Now, the other thing that I counsel patients about pretty heavily is a lot of you like to overdo it after surgery. How do you know if you're overdoing it? Well, to be honest, that definition is different for every person. But what I usually say is no heavy lifting for 2 weeks. The first week after surgery is generally the roughest week. The second week is slightly better. In terms of recovery from a laparoscopy, everyone is different. But I do say the first 5 to 7 days after surgery are the most uncomfortable, especially the first 3 to 4 where you're getting your first bowel movement, you're problem solving through burning with urination, you've got quite a bit of abdominal pain from the incisions, and lower pelvic pain and cramping from the actual surgery. Now, what are things that are abnormal? Well, a fever, which is a temperature over 100.5, is always abnormal, and we always need to know about that. Additionally, I have had patients who will be a little bit too active and carry something that they shouldn't have carried, or perhaps they went on a 1-mile walk right after surgery. Well, the interesting thing is you usually won't feel the pain of what you just did that day. You'll feel it the next day. And so our patients often will call us and say, hey, I went for a 1-mile walk and I thought I was doing great, and then the next day I feel like I got hit by a train. The truth is that's pretty common. Your body can't quite catch up to what you did until kind of the next day. And so if that's the case, it's pretty rare that you've done anything to majorly injure or harm what we did. You can always call us and talk to us, but in general, it's pretty rare that you've harmed something. It's more that your muscles are pretty sore, and so you may need to take more pain medication to kind of cover for the fact that you overdid it that first day. Now, vaginal bleeding after laparoscopy, either hysterectomy or just regular laparoscopy, is not uncommon. I usually tell my patients anything greater than a pad per hour is abnormal, but anything less than a pad per hour we're very forgiving of. Meaning, especially after a laparoscopy where we didn't take the uterus out and the uterus is still there, it's pretty common to have a fair amount of bleeding after that because the uterus has gone through a stressful situation. And so we're kind of giving it a break to let it recover from what just happened. And so keep in mind that if you've had something like a hysteroscopy, which is where we're looking inside the uterus with a camera, a lot of that fluid, that water, and that blood can try to come out at once. As long as it's not an egregious amount greater than a pad an hour, we're very forgiving of that. Okay, some more insight into what to expect right after surgery. So we roll you to the operating room, we perform your surgery, and then after surgery, I'll typically walk with you to the postoperative care unit. At the postoperative care unit is where I usually phone your loved one. I call them and I talk to them about what we find. Do I ever come out? Certainly I come out if there's something serious or worrisome that I need to talk to your partner, spouse, or colleague about. But in general, I usually try to stay with you in the postoperative care unit, watch how you wake up, watch your vitals. Now, will I talk to you after surgery? Generally speaking, I do talk to you after surgery, but there is some retrograde amnesia that patients have in the postoperative care unit, and so it's hard to remember. So what I usually tell patients is I'm happy to send you what we found during surgery through the portal, and that way once you're a little bit more awake, you can read through that and get a better insight into what happened without feeling the pressure to have to be able to remember everything right after surgery. Additionally, at your post-op visit, which you're usually scheduled for several post-op visits, one with my PA Allison as well as myself, we review everything that we found at the time of surgery and we discuss what the next steps are. Now, sometimes we're waiting on a pathology result. I usually tell patients it depends on the nature of what we're doing, but for instance, for endometriosis, some endometriosis is super obvious and some isn't. Some of it can look clear. And so in those scenarios, a lot of times I have to do a biopsy and send it off to pathology and wait for the final pathology to come back for me to have a clear answer as to staging and amount. So I just warn people, sometimes we kind of have to wait on that pathology. That pathology can take 3 to 7 business days or so. And so it's kind of a waiting game, but as soon as I see it, I send you a message through the portal and tell you what we saw and what we think. If there's ever anything concerning, then I reach out to you personally by phone and I try to get a hold of you myself. But just keep in mind that sometimes we are waiting on that final pathology to give us better insight. Additionally, what are the things after surgery that you need to look out for? What are the bad things that can happen? I mean, as we mentioned earlier, bleeding, infection, injury to surrounding organs are the biggest concerns with any surgical procedure. There's always a risk that surgery doesn't improve or help pain or whatever the outcome may be, whether that's fertility. There's always a risk that we can't do a complete surgery. That is always possible. And I always warn patients there is a risk that you'll need a repeat surgery. That's rare, but that is possible. There is a risk of an open surgery, meaning a large incision. There is a risk of a prolonged hospital stay. And I tell people, sometimes the intangibles of surgery are kind of the hardest or worst part about surgery. And so what are the intangibles? Well, let's say you don't get a major complication from surgery, but what if you get a pretty significant rash? You didn't know you were allergic to something. We used that something and now you got a rash. Okay, now that rash is pretty itchy. It's complicating your postoperative course. We have to do an oral steroid taper. That oral steroid taper doesn't jive well with you. So I warn people, or what if someone develops a postoperative infection inside the abdominal cavity after surgery? That's really a pretty rare event, but if it happens, that patient may require IV antibiotics, or interventional radiology might have to guide a drain there. That patient has to maintain that drain for several weeks. So these are all things that are kind of what I call the intangible suckiness of surgery, which is, of course, we never intend for that to be something that we do for patients or have to do for patients, but one patient might be the unlucky one that requires some type of postoperative surveillance or something to fix a problem, and that can be really frustrating and create a prolonged recovery and affect things for the future. Additionally, in terms of recovery, if somebody is having a tough time recovering, we can always augment their postoperative FMLA. I do tell patients, we base it on how you're doing, and if you need more time, if we need to send you for PT, if there are other things going on that we need to reassess, then we can certainly reassess those things within reason. So keep in mind that depending on how you're doing, we can reassess whether or not going back to work or school is reasonable. If you're ever unsure of the answer to a question, you can always reach out to us. I usually tell patients reaching out to us through the portal is a pretty great way of reaching out to us, because if I'm in the operating room, it's a good way for my nurses to be able to get a hold of me and tell me what's going on, or for them to answer any questions that they can answer. If something emergent is going on, certainly you can call 911. Additionally, you can call our office, and our office has an answering service that then patches through to me. Or if I'm not on call, then one of my partners can answer. Another question I get a lot is driving. So once you're no longer taking narcotic or muscle relaxers, you can drive, assuming that you feel comfortable, you feel safe, you don't feel like you're in pain or may endanger others. The other question I get is diet. What can I eat? I usually tell patients for the first couple of days, I would eat things that I don't think will aggravate my stomach, especially because I'll be on pain medication. And so that might mean not spicy, not foods that you think would aggravate, especially if you have to vomit. And then last thing, I always tell patients, recovery is not linear. It really is different for every individual. For some people, the first day might not be so bad, but the second is worse. And so be really patient and understanding with yourselves. Try not to overdo it, and try to really stay on top of your pain control as needed. The other piece is, if you're running low on your pain medication, try your best to let us know, especially during the work week, during work hours if you can. It's easier for us to try to get you that pain medication during work hours from a pharmacy, It's much more complicated when it's 1 or 2 a.m. in the morning. It's very hard to be able to get you pain medication when a pharmacy is closed. We usually have to send you to the emergency room. So if you have some foresight of the fact that you're running low on the medication, please let us know in advance so we can try to prescribe it to you earlier so that you can pick it up in advance. Same thing goes for the weekend. We're happy to write it for you, but it can be challenging on the weekend to get those things filled, and sometimes patients end up having to go to the emergency room. And so in general, it's better if we can try to do that through the work week. So if you're noticing that you're running low, please let us know and we can try to get that to you before the end of the weekend, before the beginning of the weekend. If you have questions about that, just reach out. We're always happy to answer any questions. We're here for you. We're invested in your recovery. We're invested in you. We're so thankful that you trusted us and trusted me with your care. My goal at the end of the day is to give you the best possible outcome, to be honest with you, to be transparent, and to make sure that you get what it is you need from this surgery. And the only way I can do that is with your partnership, as well as the partnership of your family and friends who are taking care of you. And so I appreciate that trust that you're putting in me, and I don't take it lightly, and I want you to recover well. I hope that this video was informative. I hope that you feel like you know more, and please let me know if you have any other questions. Take care. I'll see you soon. Okay, just a few last minute things that I wanted to make sure to add in. So in terms of lifting restrictions, I would say avoid heavy lifting for at least 2 weeks after surgery unless we instruct you otherwise. If we do make one of your incisions bigger than that 8mm incision, namely if we make that belly button incision, 4 centimeters or 3 centimeters, something of that nature, then we do want you to hold off on lifting anything over 10 to 15 pounds for 4 weeks. But in general, if you have 8mm incisions, we usually have you hold off on lifting anything over greater than 10 to 15 pounds for the first 2 weeks. In terms of time off work, it is quite variable. Everybody's different. I always say that, for most individuals, they require at least 2 weeks off of work. I have had people who do more virtual work who go back at 5 days or 7 days. And to be honest, it's entirely dependent on the person. For some people, they can go back quickly, and for others, they really do need more time off work. We're happy to give you FMLA and help you with the FMLA paperwork for at least those 2 weeks, sometimes 4 weeks, and even sometimes up to 6 weeks, depending on the nature of the surgery. For instance, a hysterectomy may need 6 weeks, 4 to 6 weeks off work, whereas a laparoscopy might need 2 weeks off of work. So it really depends on the person and what they need and what their recovery looks like. We try to work with you, and if you're really not doing well at the 2-week mark and you feel like you need more time off work, then it's appropriate for us to extend your leave within reason. I do tell people I think it makes more sense to request more time off work, and then if you feel great and you want to come back earlier, we can certainly clear you to go back earlier if you feel up to it. I do think there's a difference between types of work. If you have a work that's very physically demanding, then it's harder to go back to work sooner, versus if you have a work which is mostly virtual and seated, you may be able to go back at 4 days or 5 days post-op, but you'll be quite tired. That sort of lends itself into the fatigue picture. One of the most common complaints after the initial post-op period. So for the initial post-op period, the most common complaint is a lot of gas pain, a lot of shoulder and neck pain, a lot of discomfort. But the long-term complaint is fatigue. Quite a bit of people are shocked by the level of fatigue that they experience after surgery. That fatigue can persist. It can persist for 4 weeks, 6 weeks, 12 weeks. I've seen people really have very robust fatigue for quite a long interval of time. So please be understanding with your body. A lot of patients ask us, do you think something's wrong with my labs? And of course we can check labs, but a lot of times it's just your body's response to surgery, and sometimes your body just is tired from the whole construct of surgery. In terms of showering, you can typically shower within 24 hours. So honestly, if you got home and you wanted to shower, you can. Just let water run over your incisions. Don't scrub your incisions, but you can shower immediately after surgery. I don't really want you in baths or tubs or pools until the incisions are fully closed, which is typically the 4-week mark. In terms of travel, I usually tell people, usually within a couple of days of surgery, you can travel either by car or by plane. But ideally, I would just like for your pain to be reasonably well controlled before you elect to travel, meaning that we feel comfortable that you're capable of controlling your pain in a car or in a plane. I really don't want you to go on any elective vacations unless necessary for some reason right after surgery. In terms of incisional site care, I usually tell people, incisions like air, and so covering them up or putting lots of different creams on them doesn't really help them. Triple antibiotic ointment's not indicated. I usually just want you to keep the incisions clean and dry. Using scar treatment like Mederma or silicone sheets is up to you, but you can't really start those things until the incisions have fully healed. I also warn people, make sure that you don't expose those incisions to the sun because they can hyperpigment, meaning think of them like baby skin. You have this new fresh skin that just grew there. If you expose it to the sun, it can easily burn and it can turn a darker color for longer. So try to kind of not expose it to the sun. And then in terms of localized management of making those scars look less noticeable, once the incision's fully healed, you can buy from Amazon or CVS or Walgreens some silicone scar sheets and put those on there and help them lighten up. And then additionally, after surgery, I usually communicate to patients that, in the past, I used to come out and try to talk to patients right after surgeries, but it's challenging because quite a few patients don't remember the postoperative care period. They'll remember bits and pieces of it, but not all of it. And so usually the way that I do things is I will call your family member as soon as we drop you off in the postoperative care unit. I usually like to chart and keep an eye on your vitals, see how you're doing while I talk to your family member and explain what we found. Now, I know it's unnerving and you want to know exactly what we found the minute that we found it, but it can be challenging because a lot of times if I come and tell you what happened, if you're still not completely with it, you may not remember all the things that I tell you. And so a lot of times we focus on telling family member and relatives what the immediate thing that we found was. And then we usually send you a message that reviews some of the things that we found, and we go in more greater detail once you've actually recovered and we're seeing you at your post-op. Keep in mind that sometimes we actually need the pathology to help us inform. So for instance, if I'm staging an endometriosis patient, I don't know the exact stage until after I receive all of their pathology back, because oftentimes I need to see what the final pathology shows and what actually came back as positive and in what areas. So I do tell people sometimes it's pretty obvious what we found, but sometimes I do need to wait until that final pathology comes back to give you a more clear vision of what we found and what's going on. And then the last thing, just keep in mind that our emergency answering service is for emergencies. If you have questions that can wait until the next business day, please try to wait until the next business day to ask those or ask us through the portal. Certainly if you're concerned about something, you can call us through the on-call answering service, but if someone abuses that privilege too often, then we do have to consider whether or not they're a good fit, solely because we want to make sure that all of our patients could get good care. If you're worried about something that's emergent, just go to the nearest emergency room. Sometimes patients can wait and want to get a phone call back, but if you're truly worried about an emergency, please seek immediate care. Okay, I hope you have a good rest of your day, and I look forward to taking good care of you, okay?